to do it by slide. My microphone is muted. So unfortunately, we're not going to be able to have a full screen presentation, but rather than trying to get it all lined up, let's just go with the screen that we can see. So most of you should already know this, but it's approximately 1,800 new cases of children's cancer per year in the British Isles. That should say UK and Ireland, of which we have about 150 in Scotland, and there's an unbalanced distribution of children's cases around Scotland. Now, there's an increase in incidence since the 1970s. Can anybody who's not based in Glasgow tell me why that is? So there's two folks I know who are based in Edinburgh. It's fine if you don't know, just tell me I don't know, and we'll move on.
I don't know.
Okay, that's very open and honest of you. Thank you very much indeed. Anybody else want to shout out I don't know or hazard a guess?
I don't know.
Okay, so what imaging modality came in the 1970s? Boo Boo, put me out of my misery.
We're guessing here Chernobyl.
Chernobyl. Well, Chernobyl actually did increase. What did Chernobyl increase the incidence of?
Thyroid.
Oh, somebody said something. Who was that?
Thyroid.
Thyroid. Thank you, Linda. But unfortunately, it was in most of the thyroid carcinomas were in adults, not in children. There was a slight increase in pediatric thyroid cancer in children in the Ukraine, interestingly not actually in Russia, and a bit in Belarus, which was downwind from the Ukraine at the time. Now it's CT scanning. Only Linda and I are old enough to remember what a CT scanner is, and then an MRI came along. So what this is saying is that there's not been an increase in biological tumours, or very likely only a very small one. It's all about us being better at finding them, and most childhood cancers are in children under the age of 5, and if ever you've been on a paediatric ward, you won't be surprised by that. This is really important. It's the second leading cause of childhood mortality after injury. So if you get rid of accidental death, cancer is still the biggest cause of death of children in the developed world. That's probably going to be overtaken by neurological conditions fairly shortly, because we are learning how to look after neurological conditions. They now have late survivors, but I still find that quite surprising, because on average, again, what proportion of children with cancer do we cure?
Over 80%.
Yeah, over 80%. Thank you very much indeed. And for ease of math, we'll say, okay, we've got 150 new cases per year in Scotland. So how many of those are going to not be cured?
30.
30 per year. Okay, so in the whole of Scotland, approximately 30 per year are going to die of cancer. And if that's the largest cause of childhood mortality, it tells you A, how few children are dying, and B, that the majority of children, it's in single figures when you're thinking about things like cardiac disease or neurological disease. So just some thinking for you. And let's have a look at this. So distribution of children's cancers, all you need to know about this is that it's the 3 Bs. It's blood, it's brains, it's bumps. And bumps are solid tumours that are not in your brain. So just try and remember all that. That's the same information, but as a bar chart. What it shows you is that leukemia, if you think of leukemia as a single diagnosis, is the most common diagnosis of pediatric malignancy. However, it only constitutes about 1/3 of children with malignancy. It's just that Bubu's now doing haematology, so he now knows there are only 2 hematological diagnoses. There's AML and there's ALL, essentially. So I know that's going to cause rancor amongst my haematology colleagues, but although they spend a disproportionate time in hospital, actually 2/3 of the work of malignancy is in non-leukemia patients. And here we go. Why is it difficult to establish diagnosis? So it's because this is really non-specific. So if you're a GP, just ask some questions again. Oh, it says at the bottom. So if you're a GP, you're only going to see 1 or 2 cases of childhood cancer in your working lifetime. And because leukemia is 1/3 of that, the likelihood is it's going to be you're more likely to see a leukemia than you are any other diagnosis. So what we think of as really common for our colleagues in primary care is incredibly rare. And so Glasgow team, if you're a general paediatrician, how many new diagnoses of cancer are you going to make as an individual each year?
Well, as I heard earlier this morning.
Say
Maybe
again, sorry?
Maybe 1 or 2.
Yeah, absolutely, 1 or 2. So, you know, if you've got a working lifetime of, say, 30 years as a consultant, you're only going to make 30 diagnoses in your working lifetime. So even though we think that it's really, really common, actually for colleagues, it's really, really rare. But the difficulty is that if you miss it, it's a total freaking disaster. So this is one of the things that you have to remember. You have to remember that children get cancer and that lumps in childhood are not normal. Why do I say that? I say that because when I was a registrar, I got a letter in the new patient clinic asking me to reassure a parent whose child had, and I'm quoting here, a normal lump of childhood. There is no such thing as a normal lump of childhood. So if you see a lump, you need to think, is this cancer? Until you've proved that it isn't cancer, then you need to do something about it. And what do you have to do? If you are working in an environment that isn't a pediatric oncology unit and you feel a lump, what do you do?
Refer.
Yeah, it would be nice if you could do some imaging locally first, but you know what? Pick up the dog, phone a friend and say, I've got this kid with a lump. I've organised an ultrasound and an X-ray. Is there anything else I need to do? And when can you see them? Thank you very much indeed. Okay, so lumps and bumps you're not sure about, refer them on. Okay, so you know. So why is timely diagnosis important? It does affect the long-term prognosis, especially in brain tumours, particularly lymphomas and soft tissue sarcomas. There's a direct correlation between time to diagnosis and outcome. Surprisingly, many other paediatric tumours, time to diagnosis makes no difference. And why is that? Why in the majority of, or certainly a sizable minority of paediatric tumours, does time to diagnosis make no difference in terms of survival? Not that it makes no difference, it makes a huge difference in terms of having to treat their families, but in terms of survival.
Because the majority of them are leukemics.
That plays into it a little bit, but I would expand on that. It's about tumor biology. So it's, if we think about our standard model of tumorigenesis, that tends to be what we think about for adult cancers. So that something starts off the size of a cell, it gets to be the size of a pea, and then it gets to be the size of a golf ball. And when it gets to be the size of a golf ball, it starts to ping off metastases, and that happens linearly over time. And therefore, the earlier you intervene, the earlier the stage of the disease is. And so can anybody think of something that is predicated on that model of carcinogenesis? what happens that very frequently in adults to the general population. How do we adapt that model? Well, that's the basis of screening, isn't it? That's if you pick something up early, then your outcome will be improved. And that's why we screen for breast cancer. And colon cancer for those of us who are over 50 and are humiliated by sending our poo through the post. But it's a very important thing to do. But pediatric cancer is much more what we call a light bulb model, where your disease stage and aggressivity is all about your tumor DNA or how it's transcribed by RNA. And therefore, irrespective of when you present, your outcome is predetermined. And that's like someone's pressing on the light. So you are in a dark room and someone turns a light and bang, you have stage 4 disease, or you have stage 3 disease, or you have stage 2 disease. And there's very little temporal effect. Now, obviously, neither of those two models is actually true. It's the way humans try and model complex biological pathways. But in pediatric cancer, we're much more towards a light switch model than we are towards a temporal model. And therefore, the time it takes to diagnosis isn't as important in outcome as you might think. However, what does it mean if a child presents late? So Boo-Boo, I'm going to come to you and Albert, and I'm going to ask you to describe what it's like meeting a family for the first time on Schehallien when they have had 9 or 10 appointments with GPs, general pediatricians, physiotherapists, osteopaths, other GPs, more general pediatricians before they actually get a diagnosis of cancer. Can't hear you, Boo-Boo.
Baby's just stepped out. He will just be back in a few minutes.
Okay, so Susan, you've piped up, so you're going to have to say what it feels like.
Not very nice.
Yeah, and what are the family trusting or not trusting of you?
I feel like there's two ends. There's some who just don't trust anyone associated with any hospital, and then there's the other cohort that are just so thankful that finally someone takes them seriously and recognises that they know their child and they knew something was wrong right from the start.
Yeah, I think you're right there. The only problem is that the ones who are really grateful at the start still have that reservoir of ill feeling towards health services, and that will come out at some point during their time on the Children's Cancer Unit. So even the ones who are grateful to begin with are going to be more difficult to deal with later on. So timely diagnosis is important, even if it doesn't affect outcome. The other thing it may do is affect therapy. So you may be able to attain the same outcome, but by having to do more aggressive things to the child, which is not a good thing. Or you may be able to ensure survival, but that your enhanced treatments will have much more in the way of late effects. So, for instance, you might be exposing someone to anthracyclines or to alkylating agents that's going to increase their chances of infertility, or, for instance, they may require total abdominal irradiation that's going to have a knock-on effect. So, although you may not affect chance of cure, you may affect the cost of the cure. Okay, so let's just carry on. And that's just an audit we did that went even essentially, this was in our emergency room. Myself and Diana did this when Diana was a trainee, so it tells you how long ago it was. Even in children presenting to an emergency room in a major children's hospital that has a pediatric oncology department, about a third of them had delay. So, you know, there's something we need to do there. And actually, what we realized over the years is this isn't about cancer, this is about rare disease. And so what we need to do is train folk to recognize when things are not adopting a normal pattern, and to refer on for those people who don't feel right. And the important thing is not that you make a diagnosis of cancer. The important thing is that you're saying this is not a normal asthmatic. This is not a normal person with anemia. I don't know what's happening here, but I'm going to refer it on to someone who may be able to tell me what is happening here. And what, you know, if you talk to the rheumatologist, if you talk to the renal guys, if you talk to the cardiac guys, they will all say, oh, we have late presentations of disease. And so you cannot expect a generalist, whether that's a general pediatrician or a general practitioner, to have the same level of knowledge that a specialist does. That would be crazy. So you have to provide them with an education and with a pathway that allows them to refer on children appropriately. So let's just flip down. So we try to identify common signs, and as you can see, all of those common signs are all present in self-limiting illnesses. But this is really, really important. So although cancer symptoms may wax and wane, they don't go away. So if you've got folk who are presenting with symptomatology that is persistent, certainly think tumour, but think this is not a normal presentation of a common condition. Now then, I'm really sorry, I can't remember what my other slides show, so I'm going to ask what else might be something that is a red flag that's worth noting. So not just persistence of symptoms, what else might you notice? Silence. Okay, it's presenting out of hours. That's really important.
So weight loss, like significant weight loss in a short period of time that wasn't planned, night sweats, prolonged fever, unexplained bruising, paleness, abdominal fullness, large lymphadenopathy.
Yeah, good. So all of those things that you said, Boo, they're absolutely right. They can also be, they're just very difficult to say that there's a specific for anything, one thing in particular. So if they're persisting and they're presenting out of hours. So let's just have a look at this. So if you look at the symptoms for leukemia, so even things you think are really, really common, so hepatosplenomegaly are only there in about 2/3 of patients. Only half of them are pale. Only half of them have fever. Only half of them have bruising. Don't know what track I came up. Sorry about that. So there are nice guidance about this. So other things that you can talk about: bone pain and the things that Boo Boo was mentioning, abdominal symptomatology, unusual bleeding, and there's your nice guideline. Lymphadenopathy is the bane of certainly my haematology colleagues' life, and Jagadish, who was one of our trainees here a few years ago, produced this with the guys from Sheffield, and essentially it's what do you do with an enlarged lymph node, which is great that someone's actually written this out, but the bottom line is refer it on. And, you know, so whatever way you go around here, discuss, you'll end up here, discuss for advice. So if you've got a large lymph node, you need to keep a very close eye on it. If it doesn't go away, you need to refer it on, is the bottom line. So that's a bit of no shit Sherlock research, but actually quite helpful. So there you go. If it's greater than 2 centimeters, increases in size over a fortnight, doesn't go away. If you've got an abnormal chest X-ray, if you've got a supraclavicular node, and Boo and I in particular remember a child with a massive supraclavicular node, or there's other systemic signs and symptoms, you should be referring them on. Okay. Back pain, as you can see, we've got loads of slides here, so I'll just crunch through these. Back pain, we say is bad. Interestingly, if you talk to the orthopedic surgeons, they say everybody's got back pain now, but essentially children should not be getting back pain. So let's just go on to some cases. What time are we due to finish, guys?
It's meant to be an hour, so I think we started a bit late, so probably 4:10. Got about half an hour.
Fine. So I suspect that the cases are the things that are going to make most folk interested. So let's just start here. So this is just saying you can get leukemia. So this is the 3 Bs: blood, brains, and bumps. Who can see the bump here? It's all right. It's an easy question. Yeah. Massive swelling at the top of the left humerus. I was bowled over by the volume of the replies I was getting there, so I just thought I'd better interpret them for everybody. And Edinburgh folk, what can we see here? Have they gone? Edinburgh guys, you still there?
There's a midline mass.
Yeah, there is, just there. So we'll come on to all of that. So here we go. 11-year-old boy, previously fit and well, goes to his GP with worsening cough, diagnosed with probable asthma, commenced on steroids and salbutamol. 2 months later, he comes again with worsening cough and shortness of breath, gets a further course of steroids. Okay. Month after that, they take a holiday. These are all true cases, by the way. These are all Glasgow cases. And they had to stop the holiday because he's too short of breath and too tired to walk. So his symptoms are getting worse. He goes to his GP, he's referred to the emergency department. So what do they see there? They see facial swelling, marked cough, tachypnea, tachycardia, asymmetry, markedly reduced air entry, and they're hypoxic. Sorry, guys. So, who is really worried?
All of us.
Good. I was going to say I'm getting very, very anxious because none of you are telling me that you're worried, and that makes me worried. So I'm going to go back to here, and I'm going to ask an unfair question. Diagnosis of probable asthma here. What was the wheeze like here?
We don't know.
We don't know, but we can guess.
One-sided?
Probably monophasic.
Monophonic wheeze. Thank you very much. Who said that?
That's me, Albert.
It's my bad. Yeah, very good. It's a monophonic wheeze. Why is that a monophonic wheeze?
That's probably caused by fixed narrowing in one of the bronchi.
Yes, it's caused by fixed narrowing in one of the bronchi. Thank you very much indeed. Or the main airway. And so if I put that up, you can see why it's a monophonic wheeze. And this is absolutely classical, okay? And it comes down to not examining patients properly. And a third-year medical student should be able to tell the difference between the classic wheeze of asthma and the wheeze of an obstructed airway. So I'm going to invite you all to tell me what the classic wheeze of asthma is.
Polyphonic wheeze?
Yeah, it's an end expiratory polyphonic wheeze. And do you think this lump here produced an end expiratory monophonic wheeze?
No.
No, absolutely not. So if it doesn't sound like your normal asthma, think, is it asthma? Is the bottom line. And we're not supposed to take chest x-rays, and that's quite right for most children with asthma. But if you've got signs or symptoms that make you doubt your diagnosis of reversible airway limitation, do a frickin' chest x-ray. and that's it from the side. Does that worry anybody?
Yep.
Yep. What are you worried about, man?
A very big abnormal mass.
Yeah, yeah. I'm amazed actually that airway isn't more compromised than it is, but that patient lies down, all of that's going to flop down that way, and they're going to get very, very compromised airway. Guys, I'm just going to break off here and apologise to my colleagues because I'm doing this from my office where they are also sitting.
Sorry,
Just to say,
talking. We'll stop talking, guys.
That's-
Apologies.
it's just that I hadn't realised I was supposed to be teaching, and we couldn't get this set up anywhere else. The office was empty at the time, so apologies all round to my co-workers. Sorry. So there we go. So what do we think's the diagnosis here, guys?
It's probably lymphoma.
Yeah, I mean, you're quite right to be careful about what it is, but it's going to be a lymphoma, isn't it? And it's going to very likely be a T cell lymphoma with a chest mass like that. Okay, so if it's not following a typical course, think, have I got the diagnosis right? Okay. We won't go into the management of anterior mediastinal masses here because I'm not sure that's going to be helpful. But here comes another one. So the clue is on the top of the slide here, malignant haematology. It's a 12-year-old boy, previously well and active, and he's an athlete. He's got 1 week history of back pain following a 60-meter sprint. And this guy was actually at the School of Sport. Suddenly unable to pass urine. 12 hours later, he's unable to walk. So he attends his emergency unit and then he's transferred up to us. What are we thinking, guys? Linda. Talk to me, Linda. Remember, I can't see you, so you can confer with Sassy and pretend that you're going to answer me.
We've got Matt who's keen.
You got what?
Aquinas syndrome.
Aquinas syndrome. Can you expand on that?
Well, he's the worrying aspects of the history are acute onset of back pain and inability to pass urine.
Yeah, absolutely. So it's pressing on his spinal cord. Something's pressing on his spinal cord. Matt, what do you think it is?
In a 12-year-old boy. Well, the top of the slide says malignant hematology. So
yes.
I mean, it could be lymphoma.
Yeah, it's much more likely, isn't it? So going on, this boy was petrified. He's got flaccid lower limb paralysis. He's got lumps over his trunk and his limbs, which is kind of giving you a hint there. Now look at this. He's catheterized and he has a neurology referral. Commenced on dexamethasone, admitted for observation, and he has his MR spine the next day. So now it's easy because it's in a oncology presentation and it says malignant hematology at the top. For the hematology oncology trainees, what are you thinking when you read this? What are you concerned about? Matt, given that it's likely to be a lymphoma?
The fact that steroid has been given, I guess, for 2 reasons. One is risk of tumor lysis, and 2 is hasn't had a tissue biopsy yet.
Yeah, exactly. Both of those. This boy could go into crashing renal failure because you've very successfully treated his lymphoma. If the nurse walks past the end of the bed with dexamethasone in his or her pocket, lymphoma is a wimp when it comes to therapy, and it will all lies, and that patient can go into renal failure very, very, very quickly, and we get anxious about that in the pediatric hemato-oncology world. We have been really, really helped by the introduction of xanthine oxidase inhibitors, rasburicase. This has a huge difference. French demonstrated that beautifully in the mid 90s. Took the British a bit of a while to catch on, but you could make this patient incredibly unwell. You know, one has to say, why else would a 12-year-old boy have an acute neurological crisis like this if it's not a lump? And you should be getting your imaging in early, and you should be talking to your hemato-oncology colleagues just to hold your hand. And there we go. So can anybody see the problem here? I'm getting that Simon and Garfunkel sound of silence coming at me.
There's a big lump pressing on the spinal cord at around the lumbar region posteriorly.
Thank you, Albert. A big lump will do me. So, listen, he had all kinds of other things going on. He's got a Burkitt's. Okay, so now this is a very odd presentation of Burkitt's. You don't need me or Matt to tell you this is a very odd presentation, but it is. What you'll find is there is no standard presentation of a child with cancer, and pretty much all of their presentations are a bit odd. So he's a nice example. Now, the other thing is, since we made this slide, we have also had a boy present to us who was catheterized in casualty in our own emergency room, may I say, was catheterized. They relieved his acute abdominal pain. Then what did they do? Albert, what's the most crazy thing you can think of? Child comes in as a teenager in acute retention. You catheterize him, relieve his pain. What is the maddest thing you could do?
Well, take the catheter out and send him home.
Correct, on both accounts. And guess what they did?
Both?
Yeah, they did. Took the catheter out and they sent him home. Top-tastic. And he presented to his to another hospital the following day in acute retention, who then had the sense to stick a catheter in him and talk to us and say, do you think this boy might actually need your help? And he had a massive pelvic Ewing's. And you just, you know, 14-year-old males do not go into retention. This is all about pattern recognition. No one would have expected anybody to make a diagnosis of a pelvic Ewing's at that point unless they were a card-carrying hemato-oncologist. You would expect them to go, isn't that a bit weird? Maybe we ought to have a look. Does that make sense? I'm taking it from the science. It does. Okay, so that's good. All righty. So we've got a few here. But let's just go on here. Get you onto a new case. Sorry about this. Am I going in the right direction? That's better. Okay. So we'll now go on to a solid tumor. We've got 10 minutes left. So you've got a 10-month-old baby, previously fit and well, tending with a history of being generally unwell, off their feet, unsettled, hot. Now, until we get to that point, what are we thinking? This is October, November.
Sepsis?
Sepsis, yeah, could be sepsis. I was thinking RSV. I'm desperately trying to keep my eyes open, thinking I'm not in the least bit interested in any of this. But then we've got this. Bruising on the eyes, presumed secondary to a recent fall. Lump on side of head, also presumed secondary to fall. Now, this was lifted directly off the ER attendance card. So who was making the presumption?
Was it the parents?
Yeah, you'd love to think it was the parents. Unfortunately, no, it was the GP that they had seen a couple of days before, and the presumption was then copied down by the emergency room trainee, and it was a middle grade, it wasn't an SHO, who just accepted that as normality. So, oh, look, there we go, a bit of a bruise on the eyes, bit of a fall, bit of a lump on the head, probably the fall as well. You know, so what's the, from a general pediatric point of view, what are we all concerned about there?
NEI.
Thank you. Okay. Oh, look at this. Numerous attendances to the GP and the emergency department increasingly concerned. Does that make you more worried or less worried that this is NAI?
I would say less.
Less worried.
Yeah, because the parents are doing what parents should be doing, which is taking their unwell child to healthcare practitioners, and they're to be congratulated that despite everybody telling them that they're being neurotic and their baby's virally, they keep on persisting. Look at this. Okay, guys. So there is a thing about, if you've got an unwell baby, do an exam. Partly because it's reassuring the parents, but also partly because you won't miss the bleeding obvious. Baby was noticed to be hypertensive and upset. Noticed to have a large abdominal mass. So there's no prizes here for telling me what's the diagnosis, guys.
Neuroblastoma.
Yeah, thank you. Why have they got neuroblastoma? Or what tells you that it's neuroblastoma?
The blood pressure, abdominal mass, and the eyes and the skull sign.
Yeah, absolutely. What about the personality and behavior? Why is that happening?
Some upsets and fractures. Maybe it could be secondary to all the catecholamines they've got running around their body.
Yeah, so it's either, because it's probably both, the catecholamines hosing around their body and pain, and both. And you know, that catecholamine response, that's like front riding on a roller coaster as you dip down from that first great big chug up to the top, and you get that great big adrenaline surge. Now that's fun because you know it's going to stop and you know what's causing it. And it's the same that you get if you're out skiing and you're on, you know, you're on a double black diamond, or you're off piste and, you know, staring down the side of a cliff and you're taking yourself down there. You know, that's why people do that stuff, because they love the adrenaline. But that's when you're in control of your adrenaline. When you're not in control of your adrenaline and you're sore, it's horrible. And one of the things we see when we treat these children with high-risk neuroblastoma is we switch off their catecholamines within 24, 48 hours. And even if they've got a body still full of lumps, bumps, bruises, they look like they've got cauliflower sprouting out of various bits of them, the mum and dad say, I've got my baby back. And that's because you've turned off their cats. Okay, so high-risk neuroblastoma. Where are we going? Have I gone the wrong direction again? I have, haven't I? Sorry about that. So learning points from no, have I jumped? So there we go. So there you go. There's the there is the mass. So as you can see, it's very helpfully put on a 10 centimeter mass. Now, you know, that's why you could feel it in the abdomen. It's quite impressive. And there's the lump that happened because the baby fell off the counter. And oh, Matt, I hope you're excited. Talk to me, Matt. Has he gone?
Sorry, I've just come back in and I'm looking at a blood film.
Yeah. See how good oncology training can be.
Yeah, those are blood cells.
Those are blood cells. Yeah.
But yeah, there's a big clump of nasty-looking cells in the middle.
Fantastic. Yeah. So tell the guys what that is.
Well, when you see a clump like that, you usually suspect a non-hemic malignancy.
Yeah, exactly. So that's a lump of neuroblastoma sitting in their bone marrow. So lovely. Thank you very much indeed. So isn't it nice to come back into the teaching to find that there's something up that you can actually comment on? It's always good, I think. So here we go. So neuroblastoma. So what did we put for learning points for that? You know, if people are pitching up lots of times, it's correct that parents are going to be anxious. Think about examining the abdomen. If they've got bilateral bruising, guys, it's called raccoon eyes. Now, I've never seen a raccoon. I've only ever seen them in the movies or in the cartoons, but it's absolutely pathognomonic if you see it. And it's always tempting to say the blood pressure's high because the baby's screaming or got the wrong size cuff. All of those may be true, but in the context of everything else, not true. Okay, so there's some raccoon eyes for you, and that's the child's MR showing the lumps of neuroblastoma behind. Okay, so we'll just rapidly do a brain tumor. It's an infantile one. So 4 months old, health visitor GP reviewing for increasing OFC. So that one sentence, what is every pediatrician in this room doing now? Does one review a child for increasing OFC? Or if one does, how does one do it?
Should refer, I think.
I think you're right. And vomiting, lethargy, irritability, it's like we've made this up. New squint. It was the grandparents, and this isn't unusual. Parents say, oh, no, it's fine. GPs are looking after us. Leave us alone. Grannies, as soon as they get their hands on the kids, go, OK, fine. This is not right. And they've got the gumption and the I'm so old I don't careness to just go and present and go sort this out. And here is this child's chart. I kid you not. So here's birth. Right? Sorry, it's not birth. What am I talking about? This is at presentation here when they first started monitoring. What do we think of that? Monitoring at 20 weeks there.
They should have just referred for at least a cranial ultrasound at that point.
Wouldn't you have thought? I mean, you've got to commend them because they've done 1, 2, 3, 4, 5, 6, 7, 8, 9 visits to confirm a large occipitofrontal measurement. But you know, that's the 99.5th at 45 centimeters or 44.5. 49, that's not your tape measure giving you a hard time. That's the head giving you a hard time. What's happened between here and here, or here and here?
We've had
Really
intervention,
easy.
possibly neurosurgical, a shunt maybe.
Yeah, it says on the bottom here, I never ask difficult questions. It says craniotomy for resection of left hemispheric tumor. So that's why the head circumference has gone down, because they've had some therapy. So again, this is a bit of no shit Sherlock moment. The child had squint, bulging fontanelle, was irritable, macrocephaly, and delayed milestones. And there you go. So that's a large tumour in a 10-month-old child with dilatation of the ventricles, midline shift. It's got the whole 9 yards there. Okay. So unfortunately, this child had an ATRT. That's an atypical teratoid rhabdoid tumour. That's a highly malignant brain tumour, as we've said there. And this is actually one of those cases where it would have made no difference if they were diagnosed down here, because biologically this is bad disease. But it would have made the whole treatment plan an awful lot easier. There we go. We put this in to be nice. it can be difficult. In this case, it wasn't difficult. If you see that, don't take the repeated measurements, refer on at that point. Okay, so that's an hour for you guys. I'm really sorry that it was off the cuff and a bit extemporary, but I hope you get the main points I was trying to get across. So I'm going to say, Albert, what's the take-home message I'm trying to give here?
Probably if something does not feel right, either with you or the family, we should seek help earlier on rather than wait.
Yeah, fantastic. Thank you very much indeed. Now, right at the very end of this presentation, we've got stuff about Head Smart. Guys, all of you go and look at Head Smart because it is a really helpful way of thinking about the presentation of brain tumours and how different they are in babies, children and young people. There's now a similar study, Sophie Milne's group in Newcastle. David Walker did this for the brain. Sophie and David are doing it for the solids. So there's a similar thing for solids where it highlights what the worrying signs are and what you should do about it. And what's interesting is they make it a parent and patient information thing as well as a doctor information thing. So that's me done. Is there any questions, or are there any questions? No. I take it from that silence there's nothing there. If you could all go on TripAdvisor or Google and give me a 5-star rating, I'd be really, really pleased. Thank you very much indeed. It's been nice meeting you all, and we'll see you again at some point.
Thank you very much, Dr. Murphy.
Okay, see you
Maybe
guys.
we'll give you 4 stars for the timekeeping.
Okay, yeah. No, 5 stars for, but in the comments you got to talk about the timekeeping.
Thank you.
See ya.
Thank you very much again.